First, I'd like to thank the organizing committee, which Dr. Kampon Srivathanakun, my colleagues, and Dr. Samai play a very important role, but including the whole staff from Ratchanakarin Institute for Child Development. I'm very happy indeed to be here because Nitya and I have been very fortunate. We were here since the foundation of RICD, and we gave the first inaugurating lecture at RICD when they opened RICD, and we have
20 years ago.
20 years ago, and we have followed all their development. I was even more fortunate when I became member of the National Research Council of Thailand, that Dr. Samai submit many research proposals, and we were more than happy to support him and visit him and help him in any way. I was very fortunate to hear what of our colleagues from abroad who have been to RICD and impressed with their facilities and their hospitalities and their wholehearted approaches to help children. Okay, in the program we're supposed to give keynote lecture, but I was fortunate also to have seen the whole program when Kampon discussed with us not a few weeks ago, just a few weeks ago. Also not knowing or didn't have any time to really meet and discuss with all the speakers. So one of our problems is to find out how broad or how deep we should talk about it. And also we realize that in this room we have many people with many background. Okay, I could not be too deep, but my most important is to trying to make sure that you understand. And I have my 50-year colleagues. We were medical students together. We met 50 years ago, 52 years ago. And we also both lab partner in the pre-med and also what you call it, in preclinical and soulmate in the preclinical. She continued the whole school until she graduated. I received the Rockefeller Foundation scholarship to study neuroscience and came back and we worked together. Okay, Nitya we were also fortunate to have the opportunity to develop National Research Council, National Institute for Child and Family Development. This is the picture, aerial picture of Salaya campus of Mahidol University, and we found the National Institute for Child and Family Development, and we work with all the colleagues in Thailand to make sure that Thai children develop, but we are not very happy with the outcome yet. There are so many stories to tell. I moved from Bangkok to the Neurobehavioral Biology Center here, to the Neurobehavioral Biology, and then we now at the Institute for Molecular Bioscience. Okay, with what happened? Okay, maybe okay. And this is our institute now, where I now serve as a retired special lecturer and advisor. And I have given up all my labs, both in neuroscience and stem cell, to all my colleagues. But they are very so kind to me. They keep me as their teacher and advisor, and I still teach 80% of the class. If you are interested, you can visit our website, where you can learn more about us. The only thing I would like to communicate is that I'm still doing research. That's why they kept me as member of the National Research Council. My research gate index is still 35.66, and my Elsevier Edge index is 24. I am on the top 5% of the researcher of the world. Okay. My previous purpose of this keynote is to define and describe autism and autistic spectrum disorder. Dr. Dongkamon has very fully talked about autism, and we have to switch because Dongkamon gave us her PowerPoint and we know what she's going to talk about. So very fortunately, Dongkamon has covered autism. But I am going to talk about autistic spectrum disorder. Nitya, why do we have to talk about spectrum from your clinical experience?
Hello, it's nice to meet you all. For this question, I would like to address that when the family found in their children, they don't come with a label that I am autism or I am developmentally delay. Just like the example that Dr. Dongkamon gave us with the delay head lag. It can be anything from cerebral palsy to delayed development as a whole, or as now that she mentioned, is associated with autism also. That's one thing. The other thing is that considering autism, it has a different shades of the manifestation. That's why in the DSM-5, it becomes autistic spectrum disorder. It's just like a prism. When you shine the light on the prism, then it becomes different colors. In autistic spectrum disorders, you can have a combination of all these three cardinal signs. That is, the first one is impairment in the social interaction. And the second is the impairment in communication, which can range from every aspect of verbal communication to only in some spectrum is only pragmatic language problem. Comparing to totally delay or no speech at all. So just you can see that there are different levels
of severity.
Severity and different aspect of the dimension of the impairment. And the third cardinal sign is this restricted or repetitive behavior. You can find also from a very mild and close to normal, like
including self-injury,
and to very severe. The very mild one, I have seen parents bring their children to consult with, oh, he is always putting the cars into lines. All the cars, he loves to put in lines. Is this mean the child is autistic? I think most of the boys and children in this world, when they have a chance, they will put their cars together. So that's not the pathognomonic sign. At the same time, we can have some children who came in with a very abnormal, in quote, repetitive behavior. So they do something with purposeless, and they keep on and on and on and on. They walk up the step, walk down the step, walk up the step, walk down the step all the time. So even self-injurious behavior. So you can see that there are, a very wide range. So when we would like to make a diagnosis, we really need to go into more details. And mostly the history from the parents or the caregivers that can help us to tell us whether or not the child has been taken care of by, providing the opportunities for the child to learn, and also to observe the child's behavior. So it takes time, I think. Then you have to come up with a diagnosis that is closest to the child. So I would say that this is very close to personalized diagnosis as well, because there is no two children having the same sign and they have the same diagnosis, because they come from different contexts.
That's why number 2, clinical sign and symptoms are plural. We don't have one, we have many. And this could be one of the most mystical or complex. However, anyway, in clinical practice, they have to develop a gold standard. And that's why back about, I think, 15 years ago, the American Psychiatric Association spent $6 million in doing research to find out from the clinical practitioner throughout U.S. and abroad, what are the something that they could form in common, and what are the indication that could be used practically, and what are the limitations. And that result into DSM-5, which different from the previous version. In the previous version, the address was more on autism, and they already talk about spectrum, but they're still not very. So the important thing about the future of autistic spectrum disorder, as Dr. Dongkamon already touched a little bit already, would be to have a clear definition, to be precise, and to be able to even explain the symptom or sign from our up-to-date knowledge. Again, another big problem is number 4 and number 5. There's not one causal factor. And in this room, I noticed also from the schedule and topic of our distinguished speaker, it covered a great range that even touch on holistic medicine, alternative medicine, and already to the point that Kampon will elaborate, precision medicine in the future. We are bringing in more of molecular biology and genetic, even though we know that extreme situation is very expensive, and not everyone, not every family, and not every child could afford it. But nevertheless, we have to find a way that this could become a policy. The most important policy is no children will be left behind. We have to go forward with all of them to give them the full benefit of, and to make them live the life with their full potential. You want to say something?
Yeah. May I add in now? In Thailand, we are now working in a nationwide early childhood promotion of the early childhood development, and we use the developmental surveillance and also developmental screening. So we start with the child population, and then to try to find out if they are developmentally appropriate to their age, and if not, then we try to help by early intervention at the home level first. And then 30 days from that, we do the assessment again. And if they are improved so much to that become age appropriate, then we help them further that they have to find out how the parents and the caregiver can help to give the opportunity to develop further. Anyway, for autistic and others developmental disabilities, including learning disability, I just talked with the Deputy Director, Dr. Smai, just a few minutes ago, that perhaps from there, this is our third year on that program. We are going to have another 3 years ahead. And from here, I think the best thing is that from those who are at risk for early childhood developmental delay, or they cannot come in appropriately, we may need something like TDAS that Dr. Dongkamon has and her group has developed to help screen again whether or not the child with the head lag, the child with the delay language development, having this autistic or not, because the intensity of the treatment or the intervention is different from the general population. So I think we have to start, if we talk about a national policy or children as a whole, then you have to start not from the autistic level direction, but from the how are you going to find out the cases in the general population of children, if you would like to find it really early. Otherwise, it will pass the time of the windows of opportunities for brain development. Then you have to work very hard and the yield is not good. So I think in practice, we may need to do something proactively and to not to label everyone with delayed speech that they are autistic, because that will create a lot of mess in the family. Thank you.
And I hope we could really spend some time on number 7, that early developmental screening and diagnosis could let us start the intervention as soon as possible, you know. And even though we just think that we have not yet the concrete diagnostic proof that the child is autistic or autistic, one of the autistic spectrum disorders, that it will lead to a much more successful intervention. And that's, I think, is hopefully the key message from this meeting. Okay, and I will quickly review a little bit before we really embark on something concrete for the future. Many years ago, Nitya and I, about maybe 45 years ago, we celebrate our 45th year of graduate from medical school last year. So we were told already since we were medical students what is autism, that it is a brain developmental disorder, and it became firmly established by WHO International Classification of Diseases, ICD-10. Okay, and it embarked on 3 domains: social impairment, communication impairment, and restrict interested. But if you look in each of those 3 domains, there are so many sub-dimensions, you know. And like Nitya said earlier, a child, mostly boy, ratio of population is 4 boy and only 1 girl. Why boy is still a mystery, and we could not explain. Many diseases which are male dominant are related to the X chromosome, because boy has only 1 X chromosome, and that makes them very high risk for a bad X chromosome. Disease like Fragile X, disease like many things that are located on X chromosome, boy will be at high risk. But the chance that the girl will have 2 bad X chromosomes is much less. Okay? But we still didn't find a good candidate gene for autism and autistic spectrum on X chromosome at all, except those related that sometimes fragile X also come up with also autistic trait and behavior. But after autism, which was older, then we have another term, autistic, Asperger's syndrome. You know, Asperger's syndrome could also make a lot of misunderstanding about autism and autistic spectrum disorder. Let me tell you a little bit about our anecdotal experience with Asperger's syndrome. In fact, we both gained insight into this field some 30 years ago, when a boy who was thought to be specially gifted, talented, you know, were sent to us for consultation by our colleagues who is the director for education for gifted child. At that time, 30 years ago, Thailand wanted to develop, like many countries, a special education program for quoted, gifted, or smart or intelligent, genius kid, you know, because everyone realized that genius or talent kids, you know, like Dr. Einstein or Professor Einstein, Albert Einstein, would be a great contribution to the whole world, you know. But this boy is very interesting. He excelled in most all subjects in his study. We met him when he was about 13, huh? 12, yeah, 12, 13 to be exact. But he had problem in few things. He was referred to us because he had problem with physical education, PE. His PE teacher wouldn't pass him because he couldn't perform a few tests like swinging on a double bar or, you know, all the things, and do a good somersault, or could clumsy. He's clumsy, you know, a little bit motor clumsy, and you'll learn more from our physical colleague, physical therapy colleague here. Of course, this is explained by the fact that his cerebellum is not functioning properly. Cerebellum coordinate all these area of work. He also has some thing about his study of Thai literature. He did not understand the multiple meaning of words. You know, in language, a word can have multiple meaning. In social, and okay, and so we asked his parent, both father and mother, to bring him to us. We learned also later from his parent that he had some fixation of idea. He's good. He's very, very good in math, in science, in English, in vocabulary. But his problem is that if he decide on something and he made an agreement, he lacked the flexibility to change in the future, you know. For example, one Saturday afternoon, he made an agreement with his father to go to have a hamburger at McDonald's along the way, you know, to going into town. The traffic jam in Bangkok, as you all know, is terrible. So after a little while, stuck on the traffic jam, his father became uneasy and just parked in front of a noodle stand and decided to take the whole family to a noodle bowl. You know, he became unbelievable mad. You know, go down to the floor and like a child tantrum. You know, At 12, he's supposed to be able to understand the situation, but he could not. He could not cope with it. Later we learned that he also did not understand other people's intention. For example, we learned that when he go to school in the morning with a little cash that he could spend for some food or some sweet or some thing that the student like, one of his friends who outsmart him will say, hey, give me all your money, I will go out and buy all the food, and you wait here, and he could sit waiting for the guy who never come up but spend all his money. The worst was when his friend teased him terribly by telling him, hey, you got a bad shirt and trouser, go into the toilet, throw me all your costume, I will bring you a new beautiful costume. He believed them, sitting naked in the toilet until the school day ended and crying that his friend never show up, until his parent has to look for him and find him sitting naked with the cloth thrown just outside the toilet. That later could be explained that he did not understand other emotional intention or whether it's real. If you are more than 50 years old, you must have seen this movie, Rain Man. How many people in this room have seen Rain Man? Please raise your hand for me, please. Rain Man. Rain Man was one of the very prominent movie. If you have not seen one, you can look at them in YouTube. Played by Dustin Hoffman, and I think Dustin Hoffman get Oscar for the first time. The movie was written based on the story of Kim Peck, who is a very interesting guy. Kim Peck is shown in this picture. He is also talent. We call Savang. Savang is someone who has something like fantastic memory. We call photographic memory. That he could remember things. He could read things very fast, remember things very fast. But in Rain Man, you know that he has the same problem with the boy I mentioned earlier, and he could not work. He had to be later on kept in an institution. But Pig was more able to read very fast, remember all the books. In his memory, he stored 9,000 books that you can ask which page, is this paragraph or this word, and he's like an encyclopedic man. But when his brain was studied, the doctor was shocked. He had not a very good brain. The two cerebral hemispheres are poorly connected because he lacked a structure called corpus callosum. This corpus callosum is almost missing, so that the two hemispheres are not connected. Maybe that's good. He doesn't have the interfering between the emotion and the cognitive. Each one of them works separately. And we also have a Thai member, loyal family member who is like that too. Okay, so later on, as Nitya mentioned, autism is not alone. Something like autism became a spectrum, and this includes autism, classic autism itself, which sometimes known as infantile autism, and it also includes Asperger's syndrome. It includes also a new twist called Rett syndrome. Nitya, what is Rett syndrome? You've seen some Rett syndrome patient?
Yes. Rett syndrome is another genetic disorder which come with the manifestation autistic-like.
And here,
these children are...
Here, I think girls are more affected than boys.
Oh yes.
And we have
because with Rett syndrome die early.
Could not do much with it at the moment. They usually pass away in the
less than 10 years old.
less than 10 years old. Okay,
and this is in the DSM-5. It is another category. It is not in the autism.
And the last part of them is so severe, so severe. All behavior become shut down until the body also could not survive. But we also have another one called Pdd-Nos. What is Pdd-Nos? Okay, by that time, the whole autism and whole autistic spectrum disorder were included in what we call pervasive developmental disorder. When we use the word pervasive, it means it's very outstanding, it's very significant disorder. And when they call Pdd-Nos, NOS means not otherwise specified. It means that they have something look like autism, but if you try to fit them to all the established, by that time, criteria for autism or autistic spectrum, they could not fit properly.
Not fit everyone.
Not fit not everything, every area that will be required by clinical standard. So it still become pervasive developmental disorder, not otherwise specified. Okay. So autistic spectrum disorder up till now is diagnosed by behavioral, on the basis of behavior. Dr. Dongkamon already mentioned this. This is because at this time, even today, we could not find acceptable one genetic or one biological marker. When I say biological marker, I mean you could draw a blood sample, send them to the best lab and say, find me a gene, find me a protein, find me any chemical, The problem is that that we did not find something abnormal. We find so many abnormal, and those abnormal are not alone in autism. They are shared with so many other things. Like Dr. Dongkamon mentioned, this head lag. Head lag could be a risk for autism, but it is not alone found in autism. It is found in many other things. But let we have the attitude that if we find anything that could make a risk to autism, we do something with it and not just wait. That's the most important message. Okay? And about autism is that previously when we were medical students, you have to wait until they were 6 years old by that previous category to give definite diagnosis. We now move back to 3 years old. And when my colleague in the UK, Cohen, who is the director of the Cambridge Autistic Research, Simon Baron Cohen, you meet him in my slide. He's one of our best champions in this research on autism, have moved them by developing checklist for autistic, that he moved them to 18 months, 18 months. And now Cohen is working, as Dongkamon already, to find even more for newborn or 1.5 to 2 month old. So that would be very useful in giving parents some guideline to do. Okay. Okay. Yeah. Have you seen any newborn or work on new? I could mention a little bit. We're lucky. She was sent by the Thai government to study at Harvard Medical School, where she met her teacher who just passed away a month ago at 99.9 years old. Only 1 month to Dr. T. Berry Brazelton. Did you tell us more about what Berry teach you?
When Dr. Naiphinich mentioned about the newborn, I would like to inform you about the newborn behavioral that we have studied for a long, long time, and the original paper was Dr. T. Berry Brazelton, and he published this newborn behavioral assessment scale since 1973. And I learned from him in 1980. And to my amazement, we found that newborn baby orient to human face. And in the alert awake period, which is about 10% of the day, if the mother is there, or if anybody who to take care of the baby is there, and their faces are about 9 to 10 inches away, and the baby is awake and not too hungry and not sleepy, then the baby can look into your eyes and follow with the eyes when we move the head like that.
Okay.
And also with the, so it means that human newborn is oriented to the human face. And if the parents know, that will make a difference in the way they care for the baby.
There he is. There he is. What are you hidden? What are you hidden? What are you? What? What? What's that? What's that? Boom, boom, boom. Oh. Oh, yeah. Oh, yeah. Oh. Oh. Oh, you're yelling. You're yelling. What are you doing? Hmm? Yeah, Smiley. Smiley.
That's great.
Cry.
Now, get up and walk aside so we can see you.
Okay.
You come back with a perfectly still face, flat face. You sit in front of me. Yeah, don't talk to me.
Could you comment on this? The study
by Melsoft. This is in 1963. Melsoft studied newborn baby and imitation of the facial expression, and you can see that they did not have any chance to see their own face, but when they see a person's face, they can imitate it right away. So if the mother or the caregiver is paying attention to the baby and play play with the baby and interact with the baby will soon very much have this reciprocal interaction. And if the mother is depressed, as you can see here,
the depressed mother on the right.
On the right, and then the baby will have a very, very tense looking and also imitate the fast depressive face. So you can see that early experience with the social interaction and also verbal interaction are very, very important in human development. And if this is lacking, which is quite common in our country and in some developing country and in the poor area, then the children will not be able to develop normally because this is the lack of the input.
And this is related to a new finding in neuroscience called mirror neuron system. Mirror neuron system developed almost completely before birth and and would be able to function right at birth. It's evolutionarily important that the child, this is a picture from a movie from France where they look at mother-infant interaction.
Amazing New Boy.
Amazing New, this baby was born not by cesarean section, by a natural birth, and not block. The mother did not get any anesthetic to block her, so the child is awake, and right away, if you put the child on top of the mother, they will know how to, by instinct, climb to the mother, find the breast, suck the nipple, get the milk. And if he's satisfied and not drowsy yet, if you look in the mother's face and the mother say, look at, the child could reciprocate back.
They purse their lips.
And this is not just behavior. Something behind is a hormone called oxytocin. Oxytocin is the love hormone. It's the hormone that starts social interaction, face recognition, attachment, social bonding. And our colleague Simon Baron Cohen just found that he was fortunate to collect a lot of mother blood at delivery, and the child newborn cord blood follow up, and then follow up them, some normal and some autistic. He found that the mother may not need to have refrigerated hand, or cold-handed, but she has some deficiency of hormone oxytocin, and oxytocin could go down if the mother has a stress during pregnancy, a severe toxic stress during pregnancy. Oxytocin will go down. Okay, there's many other reasons, but oxytocin in the mother go down, then oxytocin will not come out in the milk. And the oxytocin will not feed back to her brain to release maternal instinct, and attachment and bonding on the mother's side. The child will not get also oxytocin in the breast milk, okay? And oxytocin plays also important role because the newborn will get oxytocin move from the gut to the blood very quickly, and from the blood it passed the blood-brain barrier, and in a few seconds, a minute, not at the most, 1 or 2 minutes, it will get to the child brain and induce oxytocin receptor on the neuron in many areas of emotional brain and the brain that related to imitation, Okay, I'll make the story short. I have to say that at the end, but I will do it now. I have to repeat. You want to say something?
Yeah.
Okay, go ahead.